So in this lecture, you will learn how to do what we call classify a blood gas or interpret a blood gas. And when we assess a blood gas, which is taken from an artery in the body, we're going to use it to evaluate oxygenation. We're going to use it to evaluate ventilation, so your ability of your body and your lungs to produce and remove carbon dioxide. We'll look at your acid-base balance using that blood gas. And when we put all those pieces together, we call it arterial blood gas interpretation. This is what an arterial blood gas might look like. This is an older one so that it's not just computer-based. You'd have your normals out here. On the new computer-based ones, you might hover over the value or the item and it would have the normals that would come up. So we are going to be using, this is the normal for pH, 7.35 to 7.45. For carbon dioxide in your notes, you're going to see that we're going to use a normal range of 35 to 45, which is easier to remember and it's most commonly used. The level of oxygen varies depending on your altitude. And in most places, we're going to have a set criteria that we use to determine if there's hypoxemia, a low oxygen in your blood present. So you can kind of ignore this oxygen one for right now. We're going to look at the total carbon dioxide or bicarbonate. And what I want you to do is look at this carbon dioxide and this carbon dioxide. Do you see how this pressure of carbon dioxide has a label in millimeters of mercury, a pressure measurement? And this carbon dioxide value has a measurement in milliequivalents per liter. And we saw that milliequivalents per liter designation when we did electrolytes. And do you remember that bicarb was one of those electrolytes we talked about? So we're going to either see a blood gas report total CO2 or bicarbonate. If they use total CO2, they're talking about the amount of carbon dioxide bound to the hemoglobin, that's what makes bicarbonate, and the amount dissolved in the plasma, in the liquid part of the blood. And so they're going to use a normal of 23 to 27. If we use just bicarbonate alone in your notes, it tells you you're going to use a normal range of 22 to 26. So when I'm looking at a blood gas, and I said we're going to look at the carbon dioxide level, that's pretty easy to identify, but don't get it mixed up with this one. When we talk about carbon dioxide, and we're looking at the at the ventilation piece, we're looking for the one that's the pressure measurement, millimeters of mercury. When we look at acid-base balance and the ability of the kidneys to get rid of waste products, we're going to look at this bicarbonate or total CO2. The other thing that we get is an item called base excess or base deficit. They may label it base excess, but by using a negative number, they've told you that you really have a deficit. And the normal range we're going to use is +2 to -2. And hemoglobin saturation, that's how saturated the hemoglobin is with something, usually meaning oxygen. Okay. So let's start with the easy thing to evaluate, and that will be to look at a blood gas and evaluate oxygenation. In every altitude location, we'd like your oxygen level to be greater than or equal to 60 torr. And torr is just another pressure designation that is the same thing as millimeters of mercury. So those labels are interchangeable. So when you see torr, if you feel more comfortable using millimeters of mercury, if that's a value you're familiar with, you could substitute that there. Your saturation of hemoglobin with oxygen, and the little a means artery. This little a right here is the way in medicine we tell you that we're talking about the artery. We use a lowercase a. And your saturation of hemoglobin with oxygen should be greater than or equal to 90%. So to evaluate oxygenation, some of you have seen we can clip a little device that measures light waves on their finger, and we look at saturation of oxygen in the pulse. So we do a SpO2, and that value is in percentage. When we take a blood gas sample and we look at the amount of oxygen, the pressure that's generated by that oxygen, we get a label that's in millimeters of mercury. So these are two different ways to look at oxygenation in the blood, and there is a pattern that they kind of follow. but it's important to recognize that one has a label that is percentage. That's your saturation of hemoglobin with oxygen. And this one is going to be a pressure measurement, and that's what that P means too. Pressure of oxygen in the artery. What do you think it would be if I had PVO2? It would be pressure of oxygen in the vein. Or what if I had a capital A there? That means pressure of oxygen in the alveoli, or in the air sacs in the lung. Here's SpO2. Saturation of oxygen via pulse oximetry. And it may or may not be identical. It would be a common practice that if a patient has a pulse oximeter on that little thing that clips on their finger, that when we do a blood gas, we look at what the pulse ox was reading, and we look at what the blood gas says is the saturation of oxygen. We're also important when we're evaluating oxygen to know how much hemoglobin the patient has. If you remembered anatomy and physiology, high school biology, we talked about this when we talked about the role of red blood cells in the body in lecture 2 of this class. We said that red blood cells carry oxygen, and as they do that, it's important to remember they carry that on hemoglobin. So when we evaluate oxygenation, it would be important for you to remember to check the patient's hemoglobin level. Make sure they have adequate hemoglobin. FiO2 is the fraction of inspired. How much oxygen are they breathing in? FiO2, the fraction of inspired oxygen. And room air, the air that you and I are breathing right now, has 21%. So if we wrote that as a fraction, we do 21 divided by 100. Or we could just remember to move the decimal 2 places to the left to make a percent into a fraction. So the FiO2 of room air is 0.21. 80% oxygen would be recorded 0.80. 100% oxygen, if I took 100 divided by 100, I'd have 1. So fraction of inspired oxygen versus the percentage of inspired oxygen, so it tells you how much oxygen the patient's on. These are the definitions we're going to use for hypoxemia in the Boise Valley, and they'll pretty much work anywhere geographically. Hypoxemia is low oxygen in the blood. And for a normal, healthy person, if you or I had an oxygen level less than 80, we'd have hypoxemia. But for purposes of patients in the hospital, we usually use this designation. If their pressure of oxygen is less than 60 torr, or their saturation of hemoglobin with oxygen is less than 90%, we're going to call that hypoxemia. And if we get really nitpicky, there are different levels of hypoxemia. There's mild, moderate, and severe. We're identifying those patients that have moderate hypoxemia when we use these criteria. So you and I, we should have oxygen saturations at least in the 80s. We're going to consider, for purposes of this class right now, any patient who has a pressure of oxygen in their artery of less than 60 torr or millimeters of mercury, or if they have a saturation less than 90%, we're going to say that they do have hypoxemia. So let's evaluate oxygenation for this patient. We're going to look at how much oxygen they're on, and this is as a percent. So they're on 35% oxygen, remembering that normal room air has 21%, so they're on a little bit of supplemental oxygen. They have a pressure of oxygen, is what I'm going to look at next, of 73.8 torr or millimeters of mercury. And we said if their PO2 is less than 60 torr, we would say they have hypoxemia. So they do not have hypoxemia on the basis of their PO2 value. And this doesn't have little A's here because they tell you above it's an arterial blood gas. Excuse me. Okay, next we go to the O2 hemoglobin, or the saturation, and we have 95%. So we said unless that was less than 90. So I'm going to kind of make a note to myself that this person's breathing extra oxygen to keep them okay, but they are not hypoxemic. To evaluate oxygenation, look at your PO2. Is it less than or equal to 60? If not, we're going to say no, they're okay. Is their hemoglobin saturation less than or equal to 90? If it's not, we're going to say they do not have hypoxemia. Then the last thing we do is we look at their CBC and look at what their hemoglobin level is, because you can have oxygen in your blood, but you need hemoglobin to be able to take it to the cells. When we evaluate ventilation, when we look at a blood gas, we're going to focus on the pressure of carbon dioxide. And the pressure of carbon dioxide in the artery is determined by your ability to eliminate CO2 and your ability to, I guess, the balance between production versus removal of that carbon dioxide. So right now, as you sit listening to this very exciting lecture, you are breathing at a normal tidal volume. Your respiratory rate will help you remove carbon dioxide, and we're usually familiar with, if I increase my respiratory rate, I can hyperventilate. And what I'm going to tell you is, when you're a healthcare provider, you're going to learn that you don't just look at respiratory rate to determine if someone's hyperventilating. You look at their carbon dioxide level, because I can breathe really fast, but what if my body's producing a lot of carbon dioxide? Hyperventilation means my carbon dioxide level is low. To a layperson, it means look at their respiratory rate. To you, to determine if there's hypo or hyperventilation, as a healthcare provider, we look at carbon dioxide levels in the artery. So the reason I have some of these things listed, if you have seizures, your body is producing muscular activity. And when muscles work, the waste product of that work is carbon dioxide production. So someone who's having a lot of seizures has increased carbon dioxide levels. Someone who has a fever, because fever increases metabolic rate, and when there's increased metabolism, we have more carbon dioxide production. That would increase the amount of production. In a normal, healthy person, if production goes up of carbon dioxide, I would just simply either increase the size of my breath or the number of breaths I take to try and remove that extra carbon dioxide. But what if I'm a patient who has lung disease like COPD, and COPD is emphysema or chronic bronchitis? What if I have asthma? What if I don't have a good ability to get rid of carbon dioxide from my lungs? So when we look at ventilation, we're assessing the production of carbon dioxide in the body versus removal. And you or I, as healthy people, if our body produces more carbon dioxide, we usually should be able to remove it effectively because we have healthy lungs. So carbon dioxide, we're going to focus on the pressure of carbon dioxide in the blood. Let's look at this person. The normal range we're going to use in this class is 35 to 45. And on the quiz this week, you will have your notes that you can use. If you were in a clinical setting, you'd have the ability to use your computer, or you'll have the piece of paper that looks like this that would have the normals beside it. When we look at ventilation, we're going to look at the carbon dioxide level. So normal is 35 to 45, and I'm sorry that keeps popping up. Let's get rid of that. This patient has a lower than normal carbon dioxide, so they're actually hyperventilating. They're either producing less carbon dioxide or they are removing extra carbon dioxide. What other information would I look at to evaluate ventilation? So in your notes, we already talked about these, and in your printed notes it talks about this. This is a person who is either breathing larger breaths than they need to, or they're breathing faster, or their metabolic rate is lower than normal. And we do that clinically in a hospital. In some patients, we make them cold. There's a thing called therapeutic hypothermia in patients who've had a witnessed cardiac arrest, in babies who are born who have a hypoxic episode at birth that we can pretty much document the time period that it occurred. We put the patient into therapeutic hypothermia. We make their body cold. And we do that in an attempt to conserve oxygen, to make it go to vital organs that are important, that receive oxygen, such as your brain. And then we slowly warm that person up over the next 2 days or 72 hours, 3 days, 2 to 3 days, and we see what their neurologic outcome is. We hope that we've improved neurologic outcome with therapeutic hypothermia is the thing you would read about if you wanted more information on that. So to evaluate ventilation, we're going to look at the pressure of carbon dioxide. If it's lower than 35, the person's hyperventilating. If it's more than 45, the person is hypoventilating. They're underbreathing. You know not to just look at respiratory rate. You know that when we talk about hyper or hypoventilation in a clinical setting or with hospitalized patients, you're going to be smart enough to know to look at the carbon dioxide level. Okay, what other information would tell us about ventilation? Well, I'd like to know, does the patient have fever? Do they have a lot of metabolic activity? Or is this a person who has a decreased metabolic activity, such as a patient who has hypothermia? I'd like to know their respiratory effort. So when we interpret blood gases, we are going to use these values for this class then. If a patient has a PO2 greater than 60, we're going to say that they're not hypoxemic. If their saturation is greater than 90%, and those two would typically go together, so rarely would you have one where maybe this is 59 and this is 90, and you'd have to say, well, I don't know what to put down. The ones that I use on the quiz especially will have enough of a distinction that it will be clear to you they're either hypoxemic, or what would the alternative to that be? Hypo versus hyper. So hyperoxemic, they have excess oxygen level in their blood. The pressure of carbon dioxide that we're going to use for interpretation of blood gases is 35 to 45, and you can find all these values that we're using in your notes. The pH, that's a normal range, is 735 to 745. For bicarb, this is not total CO2. This is specifically bicarb. We're going to use 22 to 26. If we do use total bicarb, then you just add 1 onto either end of this, 23 to 27. And then base excess or base deficit is +2 to -2. Okay, base excess or deficit. Really what it does is reflect, just like this statement says, the metabolic balance of the bicarbonate. If we have a deficit or a negative number there, it means we've lost some base. And that base that we usually use is bicarbonate, because remember, this is the metabolic balance of the bicarbonate. We might lose bicarbonate due to a metabolic problem, such as maybe chronic diarrhea. Or it may be the result of a correction, meaning the body was instructed, it told the kidneys, get rid of some bicarbonate because maybe we have excess of another item, or the body's trying to balance out the pH. If the pH is very alkalotic, we have a high pH, then the body would try and get rid of bicarbonate. And so when we have a negative number, it may be that we've lost bicarbonate, either through the kidneys or maybe through things like diarrhea or excessive vomiting, and it may be a problem or a correction. If we have a base excess, that means we have increase in the amount of buffer or base in the body. And that could be a problem or a correction. In other words, it could be the cause of the problem. To get a base excess, what if I went to my cupboard, and we talked about this when we made Gatorade. We said Gatorade had electrolytes in it, and one of those electrolytes is bicarb, and bicarb is baking soda. So patients sometimes use baking soda as an antacid. That was an old remedy my dad used all the time. He would go to the cupboard when he had an upset stomach, and he'd add a couple teaspoons of bicarbonate baking soda into a cup of water, and he would drink that because it would neutralize the acid in his stomach. Well, what if he did that excessively? He would actually end up with an increased bicarbonate level in his blood. And so that would be causing the problem of a base excess. It can also be the problem, or excuse me, a correction. And the body always tries to stay in balance. Just like it tries to keep the electrolytes in balance, it tries to keep the pH within its normal range of 735 to 745. So if my pH had become acidic, then the body would save this bicarbonate, which is a base or a buffer. And so that might be the result of a correction of an acid-base disturbance. So, I know this is a lot of information and it may be confusing, but I promise you with practice it will get easier. And you have an easy way to practice this week. In your assignment folder, I actually have some practice problems and I put the answers in a separate page, but you have easy access to the answers, and so you could practice and then check your work and see if you're understanding these concepts. When we do a blood gas, we're going to look at the acid-base status, and to do that we're going to look at the pH. When we classify or interpret a blood gas, we're going to look at the respiratory piece, and the respiratory piece is a focus on carbon dioxide. Now, I talked about ventilation earlier, and ventilation means removal of CO2. Now what we're talking about is it's the respiratory system that primarily regulates carbon dioxide removal. It doesn't regulate production because that's the body, the basal metabolic rate. But the respiratory system is what's regulating carbon dioxide. The kidneys are regulating the bicarb, and we're going to call that the metabolic system. So if the problem is with carbon dioxide, we may have a respiratory problem. If the problem is with bicarbonate, we may have a metabolic problem or a kidney issue. We're going to look at the degree of compensation. The body would like to stay in balance. So as one of these goes up, the other one should go down to try and compensate, or vice versa. We're going to look at the oxygenation status, and we've already done a little bit of that. And to do that piece, we looked at the pressure of oxygen in the artery, or the saturation of oxygen in the artery, and we looked at the hemoglobin level. So when we look at the acid-base status, we're going to focus on pH. And if the pH is greater than 7.45, the higher your pH goes, that moves the blood in an alkaline direction. And when we have the alkalosis, I have a phone call coming in right now. When we have an alkalosis, we have an increased pH in the body. So anything above 7.45 is going to be considered an alkalosis. Anything less than 7.35 is an acid, because 7.35 to 7.45 is within normal limits. So look at this one. And for pH, we have to do this tricky thing. Even though the normal range is 7.35 to 7.45, the exact normal of these 2 points would be 7.4. So I want you to look at this pH. Each time you look at a pH, is this on the acid side of 7.4? Is it something less than 7.4? That would be the acid side. Or is it on the alkaline side? Is it higher than 7.4? And I know that this is the normal range, but for right now, would you look at this pH, and if I had you take your pen and write on your screen, would you write an acid or an alkaline beside this? Remember, the lower we go, the more acidic the blood is becoming. The higher we go, the more alkaline the blood is becoming. So you should have identified this pH as an acid. So we've got an acid pH, and this slide tells me to assess the pH and assess oxygenation. So I'd look at how much oxygen is the patient breathing. Well, they're breathing room air. That means 21% oxygen. I look at their pressure of oxygen, and it's 37.7. And we said anytime it was less than 60, we were going to say the patient had hypoxemia. So this patient has hypoxemia if I look at the pressure of oxygen. When I look at their hemoglobin saturation, they also have hypoxemia. Remember, this is the percentage one, if it's less than 90%. So this person has an acid pH. They also have hypoxemia. And it was a panic value, their oxygen was. We talked about critical values or panic values, and it said they notified the physician. The next thing we're going to look at, after we do oxygenation and pH, we're going to look at the respiratory status. And the respiratory status is looking at the carbon dioxide piece. So if the CO2 is lower than normal, normal range 35 to 45, that's within normal limits. Anytime the carbon dioxide is less than 35, that will move the blood in an alkaline direction. Anytime the carbon dioxide is in a high range, it moves the body towards an acid pH. So carbon dioxide can move the pH up or down. Carbon dioxide in the body is considered an acid. If I save that acid, it's going to move the pH in an acid direction. However, if I breathe deep and I remove carbon dioxide faster than I'm producing it, that would move my pH in an alkaline direction. So carbon dioxide is a gas that's regulated by the respiratory system, and it can move the pH of the body up or down depending on whether I have excess production or decreased removal, moving the pH in an acid direction, this one, or have I had an ability to remove extra, or I've produced less carbon dioxide than normal and I could have a respiratory alkalosis. So under normal circumstances, if a patient is breathing fast and deep, what would you expect the carbon dioxide to be? Well, if a person's breathing fast and deep, then production should be about the same, but removal has increased. Removal of carbon dioxide has increased. So I would bet that their CO2 is lower than normal. Would a CO2 that's lower than normal, this one, would that cause a respiratory acidosis or a respiratory alkalosis? And by using the term respiratory, I'm telling you that the condition that caused the acidosis or alkalosis is the lungs, the respiratory system. It's the carbon dioxide piece. So if I remove CO2 faster than I produce it, that would move the pH in an alkaline direction. Now, if you use arrows, that's an easy way to kind of remember this. So I remember anything that's less than 35, and I do a down arrow, moves the pH in the opposite direction. It moves the pH up, and when the pH moves up, that means it's moving in an alkaline direction. So when CO2 increases, pH decreases. When CO2 decreases, pH increases. The arrows move opposite each other. Let's look at this patient then. Their carbon dioxide level, not to be mixed up with this one. We're looking at the pressure one, the millimeters of mercury one. They have a respiratory alkalosis or acidosis. I want you to answer that question. And remember that when we have a CO2, a carbon dioxide less than normal, that moves the pH in an opposite direction. So when the CO2 goes down, the pH goes up. When CO2 goes up, pH goes down. And up means alkaline direction, down means acid. So is this a respiratory acidosis or a respiratory alkalosis? If you said respiratory alkalosis, you got it right. And if you don't know why, then you guessed right. But a respiratory alkalosis is any time my carbon dioxide level is less than 35. A respiratory acidosis would be caused any time my carbon dioxide level is more than 45. Now let's move to the metabolic system, because we've assessed oxygenation by looking at this value. We assessed oxygenation by looking at the pressure of oxygen. We assessed it by looking at the saturation of hemoglobin with oxygen. We assessed the ventilatory system. We did it by looking at the carbon dioxide level, and then we'd also look at the patient's respiratory rate and things like fever or seizure activity. When we assess the kidneys, we're going to call it the metabolic system. So let's assess metabolic status. The normal range for bicarbonate or total CO2, if we're doing bicarb, it's 22 to 26. If we're doing total CO2, it would be 23 to 27, so similar numbers. Anytime the bicarbonate drops, it moves the pH in the same direction. So because bicarbonate is considered a base in the body or a buffer, when bicarb levels go up, the pH goes up. The blood becomes more alkaline. So this bicarbonate is above its normal limit. When bicarb goes up, that moves the pH upward, and an upward pH is an alkalosis. When bicarb is removed by the body, then we have an acidosis that develops. So just like CO2 could move the pH up and down, and it gets confusing because people think, well, carbon dioxide's an acid, it should only be able to move the pH in an acid direction. However, remember that the body could remove carbon dioxide. It could remove acid, and when it removes the acid, it would move the pH in an opposite direction. When we talk about bicarbonate, the pH moves in the same direction. I save bicarb, I get an alkalosis pH. I get rid of bicarb, I get an acidosis in my blood, so a lower pH. And then base excess and base deficit, looked at that, whether I have extra bicarb or too little bicarb, so it's another way to look at that relationship between blood pH and whether I have extra or too little bicarb. So let's look at this person's bicarb. Well, this lab reported as total CO2. This is the normal range we're going to use, 23 to 27, because we're using total CO2. If we're lower than that, the pH moves in a downward direction too. And when pH moves downward, we get an acid. So this is a metabolic acidosis. We'd expect then, if the bicarb's low, we're going to have a base deficit. And we do. We are short a certain amount of bicarb. All right, let's go to the next one then. Combined pH disturbances. So I have these questions, and I want you to try and answer them to the best of your ability to see if you're getting this stuff. What direction will the pH move if carbon dioxide level is low? So what if I breathe fast and deep, and I remove extra carbon dioxide? Or what if my body's producing less carbon dioxide because of cold? What direction would that move the pH? So hopefully you know that when CO2 goes down, pH goes up. Down arrow goes with an up arrow, meaning what's happening in the blood, the pH is moving towards more alkaline. So you should have said that would be an alkalosis. What if the bicarb is high? What direction will that move the pH? And if you use the arrow format, remember that when bicarb climbs, pH climbs. And when pH goes up, that means an alkalosis. So the answer to this one, that will move the pH in an alkaline direction. What if both the respiratory and metabolic component, what if the lungs and the kidneys are causing the pH change that's the same? So in this case, if we had CO2 removal, we have an alkalosis. And we have saving of bicarb by the kidneys, or a person who ingested too much bicarb, we have an alkalosis. To tell you that, we say it's combined alkalosis. So if they're causing the same change in pH, we call it combined alkalosis. So let's look at this, and I want you to tell me if this is combined acidosis or combined alkalosis. So I'd look at my pH and I say, is this on the acid side? Is it less than 7.4? Is it greater than 7.4? So start there. And you'd write acid or alkaline. Next, go to your carbon dioxide, the respiratory piece. Is this a respiratory acidosis or alkalosis? If the CO2 goes up, which direction does that move the pH? Does it make it more acidic? Does it make it more alkaline? With the bicarb, the normal range for bicarb is 22 to 26. This person has less bicarb than they should. What will that make the pH do? So hopefully you've identified a pH less than 740 is an acidic pH. When carbon dioxide level goes up, pH goes in an acidic direction. So it moves in a downward direction. So I have an acidosis. This bicarb, when I remove bicarb, that causes an acidosis. So I have a combined acidosis. And the patient I might see this in is maybe a patient who does have lung disease. They have a higher than normal carbon dioxide. And maybe their kidneys are not working as good as they should to save bicarbonate. Or maybe they've had extreme nausea and vomiting and they've removed a lot of bicarb from the body. So I have a combined acidosis. Now we get to the sticky wicket of compensation. And compensation is when the body's trying to fix the problem. So we said CO2, was it an acid or a base? Well, we said CO2 is recognized by the body as an acid. I said don't get confused though, because an acid can still move pH up or down. When there's an increase in carbon dioxide, which direction will the pH move? Well, by now you should know. When CO2 goes up, pH goes down. It goes in an acid direction. When there's a decrease in carbon dioxide, that should move the pH in an alkaline direction. So I'm going to let you work on this bicarb piece for just a sec. See if you've got it straight. So is bicarb an acid or a base? If bicarb increases, what direction should that move the pH? And if bicarb decreases, which direction should that move the pH? So hopefully you recognized bicarb's a base or a buffer. If bicarb increased, if nothing else, remember my dad going to the cupboard to settle his upset stomach, his acid stomach, by taking some buffer, some base. Bicarb increases, pH increases. So when bicarb goes up, the body becomes alkaline. When bicarb drops, the body becomes acidic. And compensation is, here's an example of when we might need it. If a patient had chronic obstructive pulmonary disease like emphysema, and the lungs aren't good at removing carbon dioxide, that would eventually lead to a respiratory acidosis. Increased carbon dioxide moves the pH in a downward or an acidic direction. So to fix the problem, should the kidneys save or get rid of bicarb? I want to compensate for respiratory acidosis. I've gotten too much acid, so what could I do with the amount of bicarb that the body has? Well, hopefully you'd recognize that if the kidneys started to save the bicarb or the buffer, they could kind of balance out that pH. And that's exactly what the body will try to do. The body will always try to correct a pH disturbance if it's capable of doing that and try and bring the pH back within the normal range. So, is there compensation? To determine that, you're going to do exactly like this. You're going to say, is my pH acid or alkaline? And instead of the normal range right now, go to that exact normal of 7.40. So this is higher than 7.40. This is an alkaline pH. My carbon dioxide level is lower than normal. Right? Here's your normals. I have a lower CO2 than I normally would have. That moves the pH in an alkaline direction. So I have an alkaline pH and an alkaline CO2. And now we go to bicarbonate, and the bicarbonate is low. That would move the pH in an acid direction. So I have an acid here, and an alkaline here, and an alkaline here. So which system broke to cause an alkaline pH? Well, the one that's broke is the one that matches it. Here's an alkaline pH. Here's an alkaline respiratory. This would cause an acid. So I have a respiratory alkalosis. And to determine if there's compensation, I look at the other parameter. So if the respiratory system caused the problem, in this case it caused an alkalosis, are the kidneys trying to compensate? Are they trying to fix it? Well, yes, they are. They're trying to remove carbon dioxide and bring the pH more in acid. So to determine if there's compensation, we say, has that brought the pH back within its normal range of 735 to 745? Yes, it has. Okay, a ton of stuff, to make all the pieces put together. So there are different levels of compensation. Uncompensated means the other parameter. And what that means is if the pH, what parameter matches the pH? If both parameters match the pH, meaning the CO2 is acid and the bicarb is acid, we said we call it combined. If both systems cause the problem, if both of them cause the change in pH to an acid or an alkalosis, if they both match that, then there can't be compensation. So compensation is only when one value is matching the pH and the other one is not. If the other parameter is still within its normal limits and it hasn't changed to try and correct the problem, we're going to call that uncompensated. when the other parameter is outside of its normal limits, but it hasn't been able to bring the pH back within the normal 7.35 to 7.45 range, we're going to call that partially compensated. And when the other parameter is outside the normal limits and the pH is within the 7.35 to 7.45 range, we're going to call it fully compensated. So is there compensation here? I would say pH was alkaline, CO2 is alkaline. So bicarbonate is acid. So I name the disorder. And the disorder is, go back to your pH. I wrote alkaline beside this one. Which of these is causing that pH to be alkaline? Is it the CO2 or is it the bicarb? Well, it's not the bicarb, because when when bicarb goes down, it causes an acid pH. So I'm going to name this disorder respiratory alkalosis. By telling you respiratory alkalosis, I'm telling you the CO2 is lower than it should be, and that caused an alkalotic pH. Now I look to see, has the other parameter, in this case the metabolic system, the kidneys, are they trying to fix the problem? Yes. So I say, have they moved outside their normal range? Yes. Have they brought the pH back within the range of 7.435 to 7.45? Yes, I have completely compensated. So when I evaluate a blood gas, I start with the easy thing. I evaluate oxygenation first. Then I do this step next. Is the pH on the acid or alkaline side? I look at which direction the CO2 moves the pH and see if it matches that pH change. If it does, I call it a respiratory problem. I look at the bicarbonate next, and I see, gosh, if the bicarb goes up, which direction will that move the pH? Or if my bicarb is lower than it should be, which direction will that move the pH? Naming the disorder means see which of the systems. Does the respiratory system match the pH? Are they both alkaline? Or is the metabolic system the one that matches the pH? I have a metabolic alkalosis. I name the disorder. I look to see if there's compensation. And compensation can either be uncompensated, partially compensated, or complete or fully compensated. So let's practice. To do that, let's do oxygenation. We said we look at the PO2 if it's less than 60 or if the SAT's less than 90. So we have a patient who is not hypoxemic and they're breathing room air. We said we'd also look at their hemoglobin. This person's hemoglobin, normal hemoglobin for a female should be 12 to 14, for a male 14 to 18 for a male. So we have a lower hemoglobin than I should. So they have a little bit of a lower ability to carry oxygen to the cells than they normally should, but they're not hypoxemic. This is not less than 60. This is not less than 90. Next, go to the pH. Identify it as an alkaline or an acid pH. If it's less than 740, it's acid. If it's greater than 740, it's alkaline. So I'm going to write acid beside this. I'm going to go to the carbon dioxide. Normal range for carbon dioxide is 45 to 55. No, I need the Men in Black pen. 35 to 45. So this is higher than it should be. Which direction will that move the pH? Well, when CO2 goes up, that moves the pH acid. So I've got acid written beside the pH because it's less than 740. I've got acid written beside my respiratory component, so I know I have a respiratory acidosis. Now I look at my bicarbonate, my other system, my metabolic system, and I say, when bicarb goes up, and normal range for bicarb is 22 to 26, I have more bicarb than I should have. Which direction does that move the pH? Well, that moves in an alkaline direction. I name the disorder. So, acid pH, acid CO2, alkaline CO2, or bicarb. So I have a respiratory. I'm telling you it's the respiratory component that caused the pH disturbance. A respiratory acidosis. Next, look for compensation. And to do that, ask yourself these questions. If the respiratory system caused the problem, look at the metabolic system. Has it tried to fix the problem? Has it moved outside its normal range of 22 to 26? Yes. It's trying to fix the problem. So I at least have partially compensated. If it was still within 22 to 26, I have uncompensated. So I have partially compensated respiratory acidosis, and to see if it's fully compensated, I say, has it brought the pH back within its normal range of 735 to 745? And I say, yeah, matter of fact, it has. So this is really fully compensated respiratory acidosis and no hypoxemia. Acid-acid alkaline, compensated respiratory acidosis, or fully compensated with no hypoxemia. Okay, let's do another one. Start with your oxygenation. Normal range is something greater than 60, a SAT greater than 90%, and normal of this is probably no higher than 100. So when we get up in this range, we've got hyperoxia. But look how much oxygen this person's breathing. This is written as the fraction of inspired oxygen. So this is the decimal. This is 100% oxygen that the person's breathing. The good news is they have lots of hemoglobin. So they're on more oxygen than they need. They have hyperoxia. Okay, next, go to the pH. Is it acid or alkaline? Normal range is 735 to 745, but when we first look at it, determine if it's less than 740, that's an acid. If it's greater than 740, that's an alkaline. Look at your CO2. Let's see if this is a respiratory acidosis or a metabolic acidosis or a combined acidosis. So my CO2 is higher than it should be. Normal is 35 to 45. When I have more CO2, will that cause an acidosis or an alkalosis? And you should be getting most of these correct now. If not, you may want to stop the video, look at your nose for just a little bit, and then come back. So CO2, when it goes up, pH moves in an acid direction. So I have acid pH, I have an acid CO2, so I know I have a respiratory acidosis. Now let's go to the bicarb. Normal is 22 to 26. I have less bicarb than I should. Which direction will that move the pH if the body's gotten rid of bicarbonate? That also causes an acid. So what do I do when I have acid, acid, acid? Do you remember what we call that when both systems, the respiratory and the metabolic, have caused the problem? We call it combined. And when there's a combined acidosis, there cannot be compensation, because compensation is when one system breaks it, either the respiratory or metabolic, the other system will try and fix it. And if both systems are causing the problem, then they can't try to compensate. So we have, you don't say uncompensated, you just say combined acidosis. So if I read in a patient's chart they have combined acidosis, I know that their CO2 is higher than it should be, and their bicarb is lower than it should be. Okay, and we have hyperoxia. Let's try another one. pH is 7.47. Is that alkaline or acid? Is it less than 740? It's an acid. If it's greater than 7.40, we have an alkaline. So I have an alkaline pH. My CO2 is lower than it should be. Normal range is 35 to 45. I have lower CO2 when pH goes down, or excuse me, when CO2 goes down. What does that do to the pH? So do you have a respiratory alkalosis or a respiratory acidosis? Okay, so CO2 is lower than it should be. That's an alkalosis. Bicarb is lower than it should be, and when bicarb goes down, pH also goes down. That means an acid. So I have alkaline pH, I have an alkaline CO2, and I have an acidic bicarb. I name the disorder, and the name of the disorder means which system is causing the pH to be alkalotic. Well, the one causing the alkalosis is the CO2, so I have a respiratory alkalosis. I look to see, is the bicarb, is the metabolic system trying to fix it? Is there compensation? To do that, has it moved outside its normal range of 22 to 26? Yes, it has. Has it brought the pH back within the normal range of 735 to 745? No, it hasn't. So I have a partially compensated respiratory alkalosis. I'd expect, because I have a little bit less bicarb than I normally would have in the body, that I would have a base deficit. And this person has hypoxemia. They have an adequate hemoglobin, but they have less oxygen in their blood than they should, but they're only breathing room air, 21%. So partially compensated respiratory alkalosis with hypoxemia. So can you kind of guess what the quizzes are going to look like this week? Let's do this one. So acid or alkaline pH, and hopefully you answered alkaline. Acid or alkaline CO2. Normal range is 35 to 45, so you have more CO2 than you should. So you have an acid CO2. This CO2 would cause the pH to move in an acid direction. This item alone, bicarb, I have extra bicarb. That moves the pH. Normal is 22 to 26. That moves the pH in an alkaline direction. So I have alkaline, acid, alkaline. Give it a name then. Metabolic alkalosis. And metabolic tells you that it's the bicarb. Now look for compensation. Has the CO2 moved outside its normal range? Yes. So the blood was too alkalotic. The body said, hey, we can fix that. We'll have the lungs hold on to CO2 a little bit. So we'll have the person breathe shallower or take fewer breaths. And so the CO2 went up to try and compensate. Did it bring the pH back within its normal range of 735 to 745? Yes, it did. So I have a completely compensated or fully compensated, because it brought it within 735 to 745, metabolic alkalosis. And because I have extra bicarb, I'd expect that I have a base excess. Now I look at the oxygenation. Lots of hemoglobin. In fact, they have a higher hemoglobin. So their hematocrit would be high and they would have thick blood. Their oxygen, they're breathing 35%. And they're still hypoxemic. Their PO2 is less than 60. Their SAT's less than 90. They have a compensated metabolic alkalosis. And the way I know to name it, using either metabolic or respiratory, is which of these matches the pH. If it's the bicarb, we call it metabolic problem. If the CO2 matches the pH change, then we call it a respiratory. And if they're both causing the pH change, we call it combined, and then there cannot be compensation. So here it says hypoxemia with compensatory polycythemia. Do you remember when you're chronically hypoxemic, that caused erythropoietin to release more red blood cells? You have a lot of opportunities to practice this in your packet or in your assignment folder this week. Here's one way you could approach the quiz. The quiz questions, I'm going to give you 3 blood gas results. So one way you could approach them is just this way. What if I say, find the one that shows metabolic alkalosis? You may be able to just look at the pH and rule out the ones that aren't an alkalosis. So that may be one way to kind of at least increase your odds is this pH an alkalosis or an acidosis? So anything less than 740 is an acidosis. Anything greater than 740 is an alkalosis. So we have an alkalotic pH. I have a CO2 that's lower than it should be. That causes an alkalosis. So I've got alkalosis, alkalosis. I have a bicarb that's higher than it should be. 22 to 26 is normal. I have alkalosis. So now name the condition. What's causing this blood to be alkalotic? Well, the CO2 is and the bicarb is, so I tell you combined alkalosis. The person's not hypoxemic. They have adequate hemoglobin. I would expect that because their bicarb is higher than it should be, that I have a base excess, a plus number here. Let's see if we got it right. Combined alkalosis. I'm not going to put too many combined defects on the quiz because then you don't have to look for compensation, and that would remove some of those steps of the process. Okay, last thing. What if I have this? pH looks like it's alkalotic. CO2 normal range is 35 to 45, so I'd say that's within normal limits. Bicarb is 22 to 26 is normal. This is within normal limits. Base excess or deficit is plus or minus 2. That's within normal limits. Pressure of oxygen is greater than 60. Saturation greater than 90. They're breathing room air. They have a decent hemoglobin. So guess what? It's normal, within normal limits. So even though the pH, I have to look to qualify it, I do the exact dead-on 7.40. If everything else is within its normal limits, that's what you call it. This is normal, a normal blood gas. With this one, I'm just going to ask you a few questions. If a patient has a higher carbon dioxide than normal, they would either be breathing more shallow, or taking fewer breaths, or producing more CO2. And places we might see that in the hospital, what if someone got some pain medication, and a lot of pain medications suppress your respiratory drive? So what if we gave them the correct amount of pain medication, but they kind of over-responded to it, and so they take shallower breaths, and their CO2 starts to go up, and we have that happen in the hospital. Bicarb, it's usually moved up or down with things like gastric suction. If you've ever been sick and you throw up, do you remember that first stuff that you throw up? It has a pretty normal pH. But if you're really, really sick, you throw up an acid, that hydrochloric acid that's in your stomach. You're removing acid from your body. So you could either save bicarb or remove acid from your stomach. And that would regulate your bicarbonate up or down. Okay, this is a partially compensated metabolic alkalosis. You've got ones that you can practice in your packet. I just want to talk really quickly about patients that we might see some of these things in. Here's one that's impossible, and I want you to determine why. The pH is an acid. It's less than 740. The CO2 is lower than it should be. That's an alkalosis. Your bicarb is higher than it should be. That's an alkalosis. So I'd have acid, alkalosis, alkalosis, and I can't have that because there'd be no system causing it. And so either the blood sample was corrupted somehow, or the machine that's doing the sample is not correct. I can't have a CO2 that's an alkalosis and a bicarb that's an alkalosis and have a pH that's an acid. It cannot happen. All right, so think of a likely scenario. Put the pieces together. And I apologize for the quality of these, but sometimes to get paper ones I'm having to go back a ways. So you have a patient who came in, and look at their pH of their blood. We've seen kind of mild, which is considered pretty severe. If your pH is less than 7.2, your body really isn't happy. So we have an acidosis that was pretty profound. What was causing that problem? Let's look. The CO2 was normal range 35 to 45, so my carbon dioxide level was high. My bicarbonate is normally 22 to 26, so look at this base deficit. Negative 22 and negative 25, and even without the negative there, I know that that's a deficit because look at my bicarb, it's only 9 when it should be 22 to 26. So they're saying it would take this much bicarbonate to bring the pH back within a normal range if the CO2 stays where it's at. So I have acid pH and acid CO2, so there's a respiratory acidosis. There's also a metabolic acidosis, so I have a combined acidosis. And a likely scenario would be, how is a patient breathing if they have a carbon dioxide level that was higher than normal? Well, they're not breathing very well, or they're producing extra CO2. For the kidneys to only have a 9 and a 10, well, one place bicarbonate goes is if there's lactic acid. Lactic acid kind of gobbles up bicarb. To neutralize that lactic acid, our bicarb level is going to drop. And we have lactic acid when the body's not receiving as much oxygen as it should. Well, you say, wait a minute, this patient's got lots of oxygen. Look at this. They had a pressure of oxygen of 218, and they were breathing 100% oxygen. But look at this, they kind of get into trouble here. They're breathing 100%, and they're starting to become hypoxemic. They're not quite there yet. The saturation, we're close. We're there, huh? But this patient is likely a patient who had a cardiac arrest. And so They had a lot of CO2 produced during that cardiac arrest. They had a lot of lactic acid produced during that cardiac arrest that gobbled up that bicarb. And slowly we're going to get them better as we start to breathe for them, maybe with a ventilator, and we can regulate the CO2. Maybe we have to artificially give them some bicarb to try and correct this pH. And so this is probably from a patient who had a cardiac arrest, and this was the history of this patient. Okay, so practice those problems. Your quiz is available, and good luck. If you have questions, you're always welcome to post them to the Blackboard or contact me directly. And let me get to my stop.